Hello, I'm Dr. Kevin Mose, Vice President for Medical Affairs and Chief Medical Officer at Northwestern Medicine at Central DuPage Hospital. I also currently chair the American Hospital Association Committee on Clinical Leadership. In the first part of this webcast, we heard from the AHA policy experts on some of the detailed changes to the physician payment coming under the Medicare Access and CHIP Reauthorization Act of 2015, also known as MACRA. For those of you who want to hear more about those details, please visit aha.org/MACRA to view those segments. Now we'd like to have a conversation with two national leaders in the field and hear about how they are thinking about MACRA, its impact to the organizations, and how to think about engaging and educating physicians in these changes. To talk about the upcoming Medicare quality payment, why it's important, I'm joined by Dr. Judith Mellon, board member of the ACO and MSO at Lahey Health in Massachusetts, and Dr. Adam Myers, Chief Medical Officer, Chief Operating Officer of the Texas Health Physicians Group. Judy and Adam, we know that about 50 to 75%, those are the estimates, of physicians really don't know anything about MACRA. So what should organizations be doing to educate and engage their physicians in MACRA?
Ideally, organizations would already be engaging with their physician colleagues on any number of process improvement and quality improvement activities. If so, this seems like it would be a logical next step to address the changes that are in this statute in their conversation. If not, this provides a very compelling opportunity to start to work together. The changes, as we've heard, are quite material from the standpoint of transforming the way care is provided and the way that reimbursement is provided for the care that we do. But I think a good place to start would really be to start talking about data. The big difference between now and back before in the HMO days really constitutes and circles around data. Before, the efforts on care change were focused on just reduction of consumption, reduction of utilization, and that was it. There wasn't much data about quality. Now we're really seeing that the value is the proposition, meaning the quotient between quality and cost. And along with that comes the necessary data aggregation. So regardless of the path that people choose to move down, having actionable data about the quality of care that's being provided is going to be critical. And when I say actionable, here's what I'm talking about. We're used to looking at spreadsheets and numbers that say a population of patients in our health system or in our group as a whole has say a hemoglobin A1C value of 7.6 as on average. Well, I don't know about you, but I can't treat an average patient. I can only treat individual patients. So for the data to be actionable, you have to be able to take that data and boil it down to specific individual patients in a physician's panel. I recently had an opportunity to observe a rowing competition. And there were some interesting things as I was watching this rowing competition that came to mind. Obviously, the goal of rowing is to try to get faster and beat the other rowing crews. But in order to do that, the focus is not on the whole crew. The focus is on coordinating the efforts between the members of the crew and on the optimization of each and every individual stroke in the rowing. Population health is similar to that. We can talk about the overall performance of the crew and as we approach the populations that we're entrusted with. But in order to really impact that, we have to focus on the coordination and focus on optimization of each and every stroke, each and every opportunity that we have to care for the patients that we have. So it's not just the team that wins, it's actually the patients.
Judy, what do you think?
Adam, that's a great analogy. Kevin, your question about educating and engaging physicians on MACRA, what can an organization do? I look at it as the first task being to provide information and really make it ubiquitous. First of all, give us a glossary of terms so that the acronyms make sense to all of us, right? And even the longer terms. And make information available both on a push and a pull basis so that if a physician is ready at that moment to gather more information, it's available for them. They can pull it to themselves. And provide it in different formats. Provide webinars, tables, charts, graphs, text. People learn in different ways, people absorb information in different ways, and may have different needs at different times. Provide ready access to a host of useful links with accurate, precise information, and make sure that the physicians in the organization are confident that they're people on top of the upcoming changes and that the information they pull to themselves will be accurate in real time. Also provide certain opportunities for pushing information at folks so that people who don't on their own go and seek out new information are aware of the key changes that are coming. The second key, in addition to making information ubiquitous, I think, is emphasizing that this is really about choices. Physicians have a host of choices to make all throughout the strategy and implementation of this program, and assure that each physician understands what the degrees of freedom are within which they can make those choices. And I think we'll be talking a bit more about that as we go. But one of the useful things, I think, is to recognize that a physician can really tailor this to his or her practice in many instances. Certain aspects of the program are very tailorable, others of them perhaps less so. And finally, as an initial implementation piece for educating and engaging physicians, I'd emphasize clarity around role. Who is going to do what, or what category of the organization is going to focus on which parts, so that physicians can focus on the piece that we are most expert at and be confident that experts in other areas are going to be addressing those other key important components of MACRA so that we implement it in an optimal way on behalf of our patients.
So the three of us have been exposed to MACRA for quite some time now and probably feel that we have a pretty good grasp of it. Many out there probably don't feel that way. So what are the most important points that physicians need to understand about these changes?
Great question. I think physicians need to understand that this is a large panoply of options to select among, that we have the opportunity to decide what category of physician we choose to be in this new program, and we have an opportunity to select among a host of quality measures, for example, and to make many other choices along the way. It's important, as we're first approaching this, to sequence those choices so that those of us who have a certain category of choice to make are aware of what they are and what the implications of them would be. Whereas other people don't spend extra time focusing on something that really isn't a choice for them because of the size of the organization they are, or the number of patients that they treat, or the volume of their reimbursement from certain organizations, for example. So understanding what is the right sequence to make a choice, I think, is the first step for most physicians in actually implementing this.
You know how we all love change, right? And we're resistant to change. And in this situation, I guess you can literally say it took an act of Congress to change the way that we're approaching healthcare. One approach to change is to do nothing and hope that it'll go away. And MACRA, however, to those who might feel that way, MACRA passed with an overwhelming bipartisan majority. And so I don't think that it's going to change. It's not going to go away. Regardless of the outcome of elections, regardless of the outcome of other terms of Congress, the likelihood that this changes and goes away in totality is nominal. So rather than just say, yeah, I get it, it's not really coming, I hear about it, and I don't need to change, it's time to, that will be one of our messages to the providers that we work with. It's real. Ultimately, though, the other message, too, would be that this is all about enhancing the value of care for our patients, which is a good thing. It's a good thing. Granted, it requires change, but the purpose of it and the intent of it, and really the way that it's designed, is to produce good results. So rather, you can either resist it and ultimately try to play catch up and maybe face some penalties in the short term, or you can go, I get it, I understand that it represents some change, and embrace some of those changes. I remember when I was in practice every day, this represents a sea change from what I did. To traditionally, I don't know if you guys are any different, but I would show up for practice in the morning, see what was on my schedule, see what patients were scheduled, and my focus was really on the next patient in the next room. and that patient who I was seeing then and who's the next patient in the next room. Over time, I got kind of tired of the thought and the process of doing hospital follow-ups and consultations and not having all the material that I needed in order to properly evaluate that patient. So I started a process of, a few days before, looking at the schedule that was ahead and saying, okay, I have a hospital follow-up coming up. Do we have everything that we need? I have a consultation coming up. Do we have the material that we need in order to appropriately manage this patient? And so I started asking those questions 2 to 3 days proactively. Then it turned into 2 to 3 weeks proactively. Those were good things. It was good for me, because I had the information that I needed to appropriately care for the patient, and it was good for the patient, and it was efficient for the system. What we're talking about is taking that to the next level and working as a team to proactively address needs that patients may not necessarily even be aware of and may not themselves be yet prioritizing in their own health. So ultimately, the goal here is a proactive, multidisciplinary, team-based approach, which I think is good.
Mm-hmm. Judy, many hospitals and health systems have some fairly tight arrangements in contracting with their employed physicians as well as some of the affiliated physicians. With the changes in MACRA, we're also going to have to see some changes here because the incentives may not align. What do you think your approach would be or suggestions would be to deal with this?
So, Kevin, that's a great question. A lot of really important pieces to that. And I think the overarching principles are it needs to be done in a really very thoughtful way. We need to involve and evolve, both involve everyone who's involved in providing that type of care and evolve the work that we do together to best meet the needs of our patients and assure that that's matched with the way that MACRA is being implemented as best as possible, which of course requires continuous assessment. It's very complex. There are a host of knowledgeable people who spend a lot of their time looking at these sorts of matters and bringing some of those folks in to the organizational discussions about this, as well as including the physicians and the others who are involved in the care will be critical in an evolving way. Understanding what resources are needed to support physicians in providing the type of care that MACRA encourages us to provide, understanding what the impacts on patients will be, the impacts on our practices, and workflow. What will it mean for the workflow and the information technology that supports that workflow for us? Some people use the phrase volume to value to describe this. And as these kinds of efforts begin to cascade throughout an organization, it will be critical to, as I started by saying, both involve and evolve to recognize future iterations to provide best patient care.
The details of how hospitals and health systems contract with physicians and other providers is really beyond the scope of this conversation and this panel. There's so many different wrinkles in that process that it would be difficult to address here. But I would say that it's about alignment of incentives. And even before there are payment incentives associated with the MACRA, within those existing contracts and arrangements, you can create quality incentive compensation packages and bonuses that will help the system to work together with the physicians toward the ends that will ultimately be rewarded by the MACRA statutes and process. So I would encourage folks to think about what are some ways within our existing contracts and arrangements that we can change them to promote now the type of behavior that we want and will need down the line in a new payment structure.
So both of you touched on the importance of this being a partnership. So we have health systems, hospitals, and physicians. And historically, there's been tension between those. But we know as MACRA goes down the road, it is really going to be much more important that physicians and hospitals are partners. So what are the most important messages physicians need to understand about these changes, and how can they plan and help with the hospital and health systems?
Kevin, it feels to me like it's really an opportunity for us to look at who does what best. Practicing to top of license is a phrase often used about us as physicians, and I see it as applicable to everyone who works within our healthcare organizations, whether they're technically licensed or not. Where are the content experts? Who are the data experts? Who's fantastic at detail? Who can prepare a really useful track and trend chart? And do we know who those folks are in the organization? They may or may not already be labeled as such by title, but they are the sweet spot for success in this sort of a program. So assuring that each organization has identified the best skill set of each of their members and applied it to the important components, the many important components of MACRA, feels really key to me to build those synergies. And looking for synergies, there are examples where a particular skill set applied to one clinical area is extremely transferable to a very different clinical area. And without really analyzing a measure to understand whether it's something that's being done in real time or whether it's something where we have the luxury of a year to accomplish that on behalf of our patient, or is it something we need to do within a week or two? So is it somebody who came in with a sore throat and we need to have done whatever it is before they leave the office? Or is it someone who's due for a mammogram and so we have a year in which to accomplish that? Those are two extremes of the same of measures that are available to us. So a skill set that is successful at applying a program for an immediate need can be transferred to a very different type of clinical care, and building those synergies, understanding how those measures are in fact related, is really important for success in these sorts of programs, and most importantly for improving care for our patients. It also offers us an opportunity to see what we do well at, which is great, assess our strengths, and also identify what it is that would most help us to provide better care for our patient population. What do we wish we had the resources to do? How can we use this opportunity to create those resources to build a better program for a particular category of patient care or for all of our patient needs?
Hospitals and health systems are accustomed to working with physicians and other providers in their areas. But for the most part, oftentimes, even under situations of pretty tight alignment, what happens in the office stays in the office, and what happens in the hospital stays in the hospital, and never the twain shall meet. And that's been a comfortable position for everyone involved. That's not going to be adequate moving forward. It's just not. And it's going to require change in both the hospital side and the health system side, as well as on the practice side. To that end, whenever change is happening, it's uncomfortable. And the other thing that is common in scenarios with health systems and hospitals is that the administrators, and myself being one, I can say this, oftentimes feel like we understand what the other people in the arrangement need, and sometimes forget to ask what it is that they need in order to work well with us. So if the question is, what are some ways that hospitals and health systems can partner with people, I would say and encourage hospitals and health systems to ask questions rather than just come with solutions and say, where are you now? What's going on? How can we help you meet these new standards? How can we work with you to equip you? Do you have the people that you need? Do you have a care coordinator? Do you have navigators? Do you have the data that you need? Do you have the analytics that you need? Do you have adequate access to pharmacists when you need them to work with your patients on medication optimization and reconciliation? Do you have nutrition and education support that you need? Can you do telemedicine? Because those are all going to be key components of this new way of doing things. And so I would go with questions rather than assumptions would be one of the ways that I would advise hospitals and healthcare systems.
Great. Adam, right there at the end, you were talking about many things. Do you have this? Do you have this? Do you have this? And many are saying that this MACRA may be the end of the community-based physician, the independent physician, because of the infrastructure needed and the burden of reporting. What are some of the considerations that will be important for community physicians that are different than hospital line physicians?
There's a Danish proverb that says predictions are difficult, especially when it comes to the future. But with that, I would say that it's a safe bet to predict that more and more physicians will realize at the end of those open-ended conversations that they don't have everything that it's going to be necessary to meet these new ways of doing things and these new reporting requirements. So with that in mind, I would predict that the run toward alignment is going to be great. I really do. And I would remember, though, that those who are currently still independent remain independent for some very real reasons. One of them, they're probably pretty skeptical about working with hospitals. They just are. That's just real. Two, they strongly value autonomy in the way that they practice medicine. So going in with sensitivity, that not only is their payment profile change, but now I'm going to have to work with you guys. That's a real challenge, but it's a good one. It's the right thing for us to be able to do this for our patients. But having the recognition and having that at top of mind as you approach the community physicians, I think is going to be very important as they run to partner with you out of necessity.
I think another opportunity for community physicians is to be aware of the resources that are available out there. For example, their professional societies. There's a host of information available through many, if not most, of the professional societies already about MACRA. And organizations such as their local medical society, their local hospital association, and the CMS website itself offer the opportunity for physicians to consider how integrally involved they want to become with a much larger group, such as a hospital or another group of physicians. It may be that they can identify enough resources, both within their professional societies and such, and also within their own existing office staff, to be able to accomplish much of this on their own. And with that said, I think it's really important to identify what the strengths are of the staff that you have right in your own practice. Oftentimes, we find that staff who are given a full understanding of the implications, not just a financial implication or the importance of filling out a spreadsheet or getting some small piece of work done, but the impact on a patient, what it means to be able to save a patient's vision or a patient's limbs by improving the control of their diabetes, for example. That's something that we innately know as physicians. We learned it in medical school and training. And the people who we ask to help us track and trend the improvements that could lead to those positive outcomes don't necessarily know that. So instead of understanding that it's important to know what someone's A1C is so that we can hit a particular target, if they understand that the ultimate goal is to save that person's vision, that can really open the door for tremendously creative people to be able to come up with better ways to accomplish that with even with a limited set of resources.
Let me throw a wild card at you. Many of the measures we've had in the past have been process measures. And now we're starting to look more at outcome measures and the importance of that. How do you get that across to the physicians?
Great question. You know, physicians, I think innately, we often feel that the outcome is really what matters, right? And it's been somewhat frustrating along the path towards improving healthcare for some folks to feel that all that really is being measured, some people would have said, was process. So it's very refreshing for people to be able to see that the outcome actually does matter. Now that said, we're still in the evolutionary phase of building the optimal outcome measure, right? And there's a lot of creative work going on in that space. It won't be done tomorrow or the next day, which is great news because it offers all of us the opportunity to continue to evolve to find better ways to help the patients. But the move toward measuring outcomes is one that I think many physicians will really welcome. Now that said, risk adjustment is one of the key factors that's usually in the next sentence after discussing the need to track outcomes. Being able to risk adjust for a host of appropriate factors is another important criterion. It's also important to consider the volume that a particular physician or group of physicians is providing care for so that we're sure that the measures are meaningful. They can be mathematically meaningful without being clinically meaningful, and that's a critical distinction, and getting on the right side of those questions helps physicians to feel that there's a really good reason why we're working on this.
You know, each of us went into medicine for our own reasons, but few of us went into medicine just because we liked doing this set of activities. Most of us went into medicine because we wanted to be able to help influence and produce certain outcomes. We wanted to help people be more well and live a more full life. These measures and this method of payment aligns with that purpose for why we went into this field. And yes, we can't always control every outcome. And yes, every patient is different and they respond differently to different treatments. And no, not every patient fully complies with the things that we recommend. But what this is challenging us to do is to constantly refine the process with which we provide care to try to produce the most reliable high outcomes. And I think that's a good thing.
A special thank you to Dr. Mellon and Dr. Myers for their thoughtful insights today and for joining us. And thank you all for listening. For more tools and resources on the new physician payment system under MACRA, please visit the AHA's website at aha.org/MACRA.